All right, thank you. Yes, thank you, Ken. Um, for those of you who do not know, Dr. Goodman's time as Institute Director at the Institute of Bioethics and Health Policy is coming to an end at the end of May. And we're going to have plenty of time to celebrate and say lots of good things about him. But one thing I wanted to start off by saying is that um, this is a Miller School of Medicine. And one of the interesting things about schools is that ideas matter. And over the last 30 years, one of the things we can say most about Ken is that he has managed to make sure that ideas and their discussion remain a critical part of what happens at this institution. And for that, we thank you, Dr. Goodman. And I think that one of the best ways to honor Dr. Goodman is to make sure that we have a true dialogue. So in a minute, I'm going to put up some slides, and it seemed like a traditional talk, but I really do want this to be a back and forth. Let's see if I can figure out how to do all of our slide stuff now without Esther having to run forward and fix everything. All right. I can see the slides. Good, excellent. So you'll notice that this is the title of this is There is a Right Answer. And I want it to be deliberately provocative. And we can talk more about it when we get into the discussion point. But I think part of what I wanted to say is that we are truly in extraordinary times. And I think this is incumbent upon all of us to have a full-throated defense of things that seem pretty obvious. So this is a new talk for me. This is a brand new set of things. Can people, you're going to share screen. This is a brand new talk for me, but the ideas are not new. And in fact, a lot of them are so routine that you guys are going to say, he put a slide for that? Really? Do we really need that? But I think this is an opportunity for us to make sure that we are saying clearly to everyone what really matters in ethics and health policy. I'm going to talk a little bit more about the title as I go through. First thing is a disclaimer. As you guys know, as Ken said, I'm a pediatrician. Been working here at University of Miami for over 30 years. And there are a couple of the positions. Federal government in the state of Florida, I am speaking as Jeff Brosco at the University of Miami and not in any of those positions. This doesn't represent HRSA, Department of Health, or anyone else, and no commercial interests. So here are the formal learning objectives. We're going to talk about the strengths and weaknesses of scientific medicine, the role of values, beliefs, and preferences, and talk about the importance of process. And before we get into that, just a couple things about ethics in general. Just like in clinical medicine, we have all these different quote unquote basic sciences. In ethics, there's a bunch of different basic sciences too. Philosophy is probably the one that we think of the most, but there's a whole lot of other activities that we do that contribute to ethics. And also, I wanted to sort of level set on that it's being more than just principlism. Very often, people just sort of quickly lapse into, oh, it's about beneficence and autonomy and now malevolence. And that is one way of thinking about ethics. There's actually other ways of doing principlism. The Ten Commandments, for example, counts as a set of principles. It is also true for any of us who've done ethics that it's only a matter of time before the principles collide with each other. And pretty much all interesting ethics issues, that's why they're interesting. And usually principlism doesn't give you a good approach to how you choose one over the other. On the other side of the screen, I just kind of listed some of the other philosophical traditions that lead to kind of moral theory to point out that there are other ways besides principlism to think about how we solve problems. And you guys know many of these. We're not going to spend time on it. I highlight at the bottom pragmatism, which, by the way, is a particularly American tradition in philosophy, and says that it's much fancier than this, but we muddle through based on trying to make some distinctions as best we can about what's actually happening. And I think this is a lot of what we do on ethics committees and in health policy. Um, how many of you have been to an ethics talk where the speaker brings up one interesting question after another after another? Yeah, that drives me bananas, I got to say. Right. And that really what you like to try to get to is answers because, in fact, in real life, we have to answer all of these ethics issues. And so I'm going to say that we have solutions in every single case, that ethics is embedded in all the things we do, and we always answer the ethics question. Just sometimes we have better answers, and sometimes worse answers. Um, this is more obvious in clinical medicine, but I'm going to talk about, so we're not going to spend time on clinical ethics today too much, but consent, confidentiality, and so on, the things we talk about as sort of the core basis of what we do with patients. But it also fits into public health ethics. And I'm going to add another key part of philosophy, which is epistemology. So epistemology is the study of knowledge. How do we know what we know? How do we have certainty in things? And I'm going to argue that that's been something that's been missing because we're kind of losing out on the special epistemological status of science. And this is a debate, by the way, that Ken and I have been having for 30 years about what is that special epistemological status. But particularly in this day and age, it's important to say that there is something interesting and different about scientific knowledge compared to other kinds of knowledge. So if I were to take those things and just say, here are the big ideas. Scientific medicine has strengths and weaknesses, but experts can provide the best information available to make decisions. However, science does not tell us what to do. That values, preferences, beliefs matter. And it's the process that brings them together that's most important and how you get to the right answer. And so this is kind of the schematic I'll come to it back to a bunch of times. Very complicated, right? Best information available plus values, beliefs leads to sound health policy. Notice that I have process written in a bunch of different places because that's kind of thing for us to discuss a little bit today. Um, just a couple examples of what I mean by process. Um, was it Mark who gave a great talk just a couple of months ago on futility in medicine? Really wonderful discussion of clinical futility. And at the end, he got to what a lot of us get to, which is whereas defining futility is really hard, we can come up with processes which, if we follow, get us to a pretty good place. And most hospitals have a policy approach. So when we reach a point where some doctors think things are futile and the patient doesn't think they are, well, there are steps to go through, like an ethics committee, trying to transfer to another hospital, that there are ways you try to resolve it that in some ways ends up being a practical definition. And by following that process, we get to as good a place as we can. In some sense, this is what hospital ethics committees do all the time. It's not so much that ethics committee members are more ethical than others, but if you have enough different people together, diverse ideas, and then you see, okay, we're going to go discuss the case, we go through a certain process and come to some set of conclusions. It's more about that than following specific moral theory. All right, so what are we going to do today? Here's the meat of it. We're going to go through 3 case scenarios, and you guys are going to participate. Antibiotics for a child with ear infection, a 1-year-old who's due for the measles vaccine, and then school district policy on vaccination. Before we go through these, I want to take a step back and ask you to try to do something hard. And that is, there's a dichotomy, and there's a bunch of debate on how strong a dichotomy is between thinking fast and thinking slow. Our first impulse in most situations is bang, we've got an answer. And then there's this more reasoned approach that takes a little more time to get to an answer. And Daniel Kahneman, Nobel Prize winning economist, behavioral psychologist actually by training, talked about these 2 kinds of thinking. And fast thinking is like someone says 2 plus 2, bang, you know 4. Or if you see something that's like kind of gruesome, you just feel disgust right away. It's almost pre-thought. But then there's this sort of slow, effortful, logical kind of approach, where if you had a harder math problem to solve, where you're trying to weigh 2 complex options. And the reason why this is important is because the research shows that we all have cognitive bias in every decision we make. And lots of different factors fit in. The bias is much more powerful in our fast thinking. So I'm going to ask you about what do you think we should do in certain cases, and your first impulse is going to be blank. And then I'm going to ask you, well, how did you get to that? Why are you thinking that? Because I think in that portion, we can get to a better place. All right, so here's the first case. 2-year-old, clear signs of an ear infection, low-grade fever, ear pain, physical exam shows a bulging TM, no previous ear infections. So we're all going to vote now. Okay, people can vote online too. Give antibiotics, yes, no, maybe. All right, how many yeses in the audience? None. No one wants to give antibiotics. Boy, the parents can be mad at you guys. How many no's? 1 no so far, a couple no's, maybes. Bunch of maybes in the room. Interesting, a lot of maybes. I wonder why it's maybes. Yeah. Well, it's interesting. I gave this a similar. Oh, yes, Esther? 4 no's. This is an anti-antibiotic group. Um, by the way, this is the sort of academic version of this talk. I gave a similar talk to the county commissioners and school board folks in Volusia County and Flagler County a couple weeks ago. Because I think this is the kind of thing where more important than this audience is going to be audiences that actually make decisions about health policy. And their reasonable question was, well, I don't know anything about prescribing antibiotics. So the first question is, well, do antibiotics work? Right? Pretty simple question. And this, for a lot of you, because you're medical people, will be seem redundant, but I think it's important to talk about what randomized controlled trials are and why we do them. And it's one of the ways that we answer the question, does a treatment work? It's considered one of the gold standards. We don't have to talk about meta-analysis now. And for a couple big reasons. One is because there is a control. And as you all know, because you're in the medical field, when something happens, we often think that's what caused the next thing. So typically, if a family comes into me, I'm a pediatrician with a viral illness, and I give them an antibiotic, and the child gets better in a day or two, because that's what happens with viruses, they say, Dr. Brosco gave an antibiotic, that worked. Thank you very much. Or in fact, it may have had nothing to do with it whatsoever. So you need to have placebo controls. The second thing that this kind of approach does is it randomizes. It kind of takes out all the bias. And we don't need to discuss that at any length, but you guys get that idea. One example I do give is the idea of breastfeeding in child IQ. So in the United States of America, moms who breastfeed in general tend to have higher educational status than those who don't in general. So because of that correlation, their children often have higher IQs too. So if you do a research study that says, well, does breastfeeding lead to higher IQ? The answer is going to be yes, but you don't know if it's the breastfeeding or if it's all the other factors. And you can see why it'd be hard to randomize people to breastfeed or not, right? So that would be a tricky study to do. Ask parents what they think. Nope, we're not going to do that under any circumstance. The question was, should we ask parents? We're going to get there. No worries. No, but it's a perfect question. No, I want you to keep doing that. Thank you, Ken. So do antibiotics work? Here's just one randomized trial, and there are literally hundreds of them. But I wanted to give you an example of what this is a really good one, right? This is the New England Journal of Medicine, 319 kids. And look at the difference. Outcome in this case was improvement by day 8. If you gave the antibiotic, 86.3 got better. But if you gave a placebo, 74.7 got better. Right? And this is what we see over and over again. Antibiotics work, but not by much. And if you look at side effects, by the way, about half had diarrhea, but a quarter with placebo. So one of the things that comes out of this is, and this is true of most treatments in medicine, that you can show an advantage, but the advantage is actually relatively small most times. So now that you know whether antibiotics work or not, by the way, because it's impossible for any doctor to go through all of the studies about every single topic, you have to have clinical guidelines. I just wanted to say a couple words because sometimes we've had presentations where clinical guidelines are kind of misused or misunderstood. I want you to know that there is a really important approach to rules and procedures when anyone does clinical guidelines. I've been involved in these in a variety of ways over the last couple of decades. And there are, when done properly, there are strict things about conflict of interest. There are strict ideas about what evidence gets admitted. And you look at the certainty of the evidence, the magnitude of the evidence, the weighing risks and benefits. So when done well, clinical guidelines take all of those randomized controlled trials, observational trials, and come up with a pretty good set of guidelines on what to do. And most clinicians need to rely on them because you can't look at all of the literature yourself in every single topic. All right, so we come back to this again. 2-year-olds, do we prescribe antibiotics? And we know the clinical guideline says yes, no, maybe. I'll tell you about that in a minute. What do you guys say now? You want to give antibiotics now that you know that the advantage of antibiotics is there, but small? No yeses here. We'll see if there are any yeses online. Trust you a lot. No. There's the doctor. Dr. Gelman says if the mom trusts you, then no. I also want you to think about what led you to your answer, not just like gut, yes or no, but what led you to the answer. So the right answer, of course, is maybe, as you guys anticipated. This is an easy one, right? And the idea of shared decision making, that it's the best information available from the clinical guidelines, randomized controlled trials, and meta-analysis, but then the values and preferences of the individual person are important. And this leads to this idea of autonomy. It's sort of the basis of clinical medicine, that individuals with capacity and sufficient information who are not coerced can make the decisions. Again, science rarely tells you what to do. There are cases, right, where the randomized controlled trials are overwhelming, that there's a huge danger to the child. And those are the rare cases of medical neglect, where we worry about child abuse and so on, where we will overrule parents. But by and large, it's usually, reasonable people would disagree. What's the process? Well, this is, as Dr. Goodman pointed out from one of the chat folks, ask the parents. And this should be the key thing we do all the time. This is what we teach our medical students and residents. So your child has an ear infection. 8 out of 10 kids with an ear infection get better on their own. If you give an antibiotic, maybe one more gets better. It's a little bit different, but not much. But some kids will get diarrhea and talk about the side effects, whatever. And then I like this formulation. It's something like um, some parents would say, I prefer to let nature take its course. I want to avoid antibiotics. I don't really like them. Other parents would say, I want to try anything that will help my child, even if it's just a small difference. And then other parents want me, the pediatrician, to make the decision. How do you feel about this? And the idea is that you make it clear what the different choices are. You make it okay for those choices to be there, but you don't force them to choose. Because some parents like, I don't want that pressure to decide. In the 20 something years I've been doing this, it's about a third, a third, and a third of my practice of what people want. And then they say, Dr. Brosco, what would you do if this were your child? What's the right answer? The right answer is it's irrelevant. And the reason why it's irrelevant is because my values may be different from yours, right? It's like ordering dinner. Some people like liver, some people don't, right? It's not that. But if I said it's irrelevant, they'd think I was a jerk. So I have this thing that I say, which is, well, if you ask me, I wouldn't do antibiotics because I think nature is going to figure this out. But if you ask my wife, she would say antibiotics because she wants anything that might help. So you might be more like me, you might be more like her. What do you think? Right? So you can answer the question without being a jerk, but also make it clear that I want to come back to my job as a clinician is to help you sort of figure out what are your values and preferences. All right. So that's a pretty straightforward one, right? This is the one we do all the time. Antibiotics have risks and benefits. Ask the family about their values and beliefs. Shared decision making. We get to the right decision. And I say right because reasonable people can disagree. The right one is when someone has included the best information available and then it matches their values and preferences and beliefs. That's the right answer. Okay. Now we get to the harder questions. So now this is a 1-year-old comes in for regular checkup, developing normally, everything's fine. 1-year-old is when you get the MMR, which is measles, mumps, rubella vaccine. So what do you guys think? Do you guys recommend the vaccine? I'm seeing a nod, a yes. Dr. Gelman, you're withholding your statement. He's saying yes. You're recommending it. Anyone, any no's, any maybes? Interesting. Okay. So let's go through the same kind of process with the MMR. Do vaccines work? Yes, but I want to go through a couple examples. And I choose this one in particular. This was among the coolest experiments, right, of all time. You guys remember back in 2020 when COVID was really, really scary? When this study came out with 43,000 people, right, looking at the COVID vaccine, and they looked at cases of COVID, the vaccine, people get the vaccine, 8 of them, placebo was 162. That's huge. That is an incredible difference. Most of us were thinking that the vaccine would be a little bit effective and there'd be lots of bad side effects. Here's a vaccine which was extraordinarily effective. And the side effects, most of the biggest one were headache and fatigue, was half of the people got it, but a quarter of those placebo got it as well. This is one of many examples. There are relatively few, like measles is a hard one to do because we've had an effective measles vaccine since the 60s. And so, it's hard to go back to that. So I wanted to give this example of how things go. But also wanted to sort of educate folks that when you want to know whether a vaccine works, there is some complications because I showed you infections, how many people got infected. But sometimes what's really effective about a vaccine is that you don't go to the hospital or you don't go to the critical care unit or you don't die, but you may still get the infection. So this is true for things like influenza, where it's pretty effective for keeping you from getting very sick, but you still may get the flu. And then there are examples of long-term outcome, like long-term COVID. So for pediatric COVID vaccines, the number of children who get bad COVID is relatively small, so it's hard to show a difference, but you can show a pretty robust difference in long COVID. So vaccines do work. Are they safe? This is the question that comes up all the time. And what's hard is if you look at rare side effects, I showed you a randomized control study that looked at 40,000 people, but let's say there's a really bad side effect in 1 in 100,000, right? You may not see it in that study. So I'm not going to go through all of these, but I just wanted to point out that at least until now, the United States federal government and clinicians and manufacturers work together on a whole series of approaches to making sure that vaccines are safe. The top one is the one that probably folks know the most, which is an early warning system, basically. And physicians and manufacturers are required by law to report. So if I give the MMR vaccine and the mom tells me the next day the child's hair is green, I'm going to say that's an unusual side effect, possibly. It could just be that he went to a Halloween party and we don't know about it. So I need to report that to theirs. And then through these other systems, they'll follow up. And if they see, yeah, lots of kids' hair is turning green after the vaccine, we need to do something about this. So there are systems in place during and after vaccines to make sure that they remain as safe as can be. Um, the question about autism and MMR comes up all the time. And so I just wanted to show you this is one study of dozens looking more closely at it. And this is a study looking at about 400,000 children who are vaccinated. It's done in Denmark because they have a great healthcare information system that's basically every human in the country. And they looked at whether people had autism or other spectrum disorders. And this is particularly looking at thimerosal, which is one of the things that was in the vaccines. And what I circled here is the relative risk. When it's 1.0, that means there's no risk. If it's greater than 1, that means there is a risk. And if it's less than 1, it means it actually is a little bit protective. So in a weird way, and by the way, you have to look at the confidence interval. If the confidence interval includes 1, then it means it's not significant. In any case, if you look sort of straight down all the different things, you find that there is no association, in this case with thimerosal, with autism. And in fact, if anything, there's a trend toward it being protective, which it probably is not. This is just one of many examples looking at hundreds of thousands of children that shows there's no association that we can find between MMR and autism. Now, what happens, and as a general pediatrician, I also specialize in taking care of kids with autism and other developmental disorders. Parents will tell me he was doing fine, he was great, he was normal, he got his vaccines, and 2 days, 2 weeks, 2 months later, he stopped talking and everything fell apart. And when families tell these stories, they are emotionally incredibly powerful. And trying to talk them out of it is not going to be useful. But it is the kind of thing that then those stories carry so much more weight than this abstract, large scale observational study. You guys get that? One other thing about vaccines or other environmental causes of autism, because as you may have noticed, this is a big part of what Health and Human Services will be focusing on at the federal level. This is looking at maternal inflammatory proteins. So you don't have to see the details of it, but this is about 35 different proteins measured in mothers while they are pregnant that in some ways reflect inflammation. And in this case, the way I'm showing you the diagram is where it's circled, if the bar graph does not include this line, it means it's significantly associated. So this is looking at any neurodevelopmental disorder, and this is looking at autism in particular. And you see there are at least 24 maternal inflammatory proteins that are associated with autism and ADHD and other sorts of things. This is in utero, long before any vaccines. Now, what does this mean? Well, is there an underlying genetic cause that leads to inflammation, which leads to different sorts of things and changes in the brain? Is it there's a genetic plus environmental interaction? It's possible. The key thing to point out, though, is that there is really strong evidence that what's happening with autism is starting in utero, long before you get anywhere near any vaccines. So just another example of the kind of, this is a study that just came out last month, of the kind of research that makes us feel confident that vaccines are safe and effective, particularly when we think about autism. And then the clinical guideline, here it is. There's an advisory committee on immunization practices, and their clinical guideline calls for the MMR at 12 to 15 months of age with a booster. All right. Anyone change their minds? They're all yeses. Any no's? Okay. Um, so same idea. We have the CDC guidelines, values, beliefs. That's the family shared decision making. We get to the right answer. But this is a little bit different, right? Because a family saying no here has greater implications because measles is so contagious. So if someone decides not to get the measles vaccine, as is happening in Texas, where sort of clumps of people have decided not to, then measles starts spreading. And then there's a risk to people who can't get the vaccine. So infants, people with cancer, any sort of immune deficiency. Um, They're also, the vaccine is about 97% effective, which means 3% of people who get the vaccine are not protected. When everybody gets it, right, then you have something called herd immunity. So it protects people whether they got the vaccine or not. And not to mention that the other thing is that there are a lot of resources required. So when there is an outbreak or an epidemic, right, this is people miss work because they have to take care of their kid, and there's all the public health follow-up. So there are lots of reasons why your decision about the vaccine is not just for your child, it's actually broader than that. So this brings us to the third and hardest case, which is should we require the vaccine to go to school? I'll note that I heard on the radio this morning that Florida is very close to saying fluoride should not be in the water. I don't know if any of you guys heard this story. And one of the representatives in Florida said, we are, without anyone's consent, putting medicines, toxins into the water that everyone has to drink and they have no chance to decide for themselves. That was the way it was framed. And so a lot of people frame this question as, how dare you make me do something to my child? So I realize in a medical audience, we're kind of like, of course you can get the MMR vaccine, right? But recognize that there are different opinions about this. So when I asked this question before, I've said I wanted people to say, again, think fast and slow, take your time, because a lot of things about this are about group identity. I belong to this group, and our culture, our politics believes so and so you should not be making me do something. So we quickly move away from a reasoned approach to the evidence to, okay, we need to do this for certain reasons, and also information sources can be varied by group. Um, so here's our best information available. I mentioned before, if we get 97% of people vaccinated, then we get to a pretty good herd immunity. It's less for some other vaccines, but measles is very, very infectious, very contagious. Um, the mortality is a little bit more than 1 in 1,000. Encephalitis is another big thing. Now, the side effects are real. So 1 in 3,000 children is going to have a febrile seizure, which is incredibly scary for families. But we in the medical profession know it turns out not to be that bad a thing, right? It's scary when it happens, but typically it's self-limited, it stops, it doesn't need any treatment, and kids do fine later on. And by the way, one of the ways we know they do fine later on is, again, Scandinavian studies following up tons of kids 10 years later, and they do well. Immune thrombocytopenic purpura, ITP, is about 1 in 40,000. So just think about that for a minute. If we vaccinate every single 1-year-old, that's 3.5 million children per year. So you're going to get a bunch of cases of ITP. It may be really rare for any one family, but it's going to happen in a community. So when we talk about sort of public health benefits, we have to recognize that there are side effects. And if there's no disease circulating, then you're getting pretty much the side effects and the potential for preventing the outbreak. Right now, I'm showing you on the left what's happening in Gaines County, Texas. This was as of about 2 weeks ago. 600 cases, 74 hospitalizations, 3 deaths. Um, Almost all of the cases were unvaccinated. And this is just showing, this is a CDC graph. Back in the early 60s, we'd had 500,000 cases a year in the United States of measles. So if you do that math again, that's about 500 deaths per year among children. Deaths among children, by the way, are incredibly rare nowadays, extraordinarily rare. You know, a few hundred maybe in Miami-Dade County. We've got close to 800,000 children. And then since the vaccine was licensed, you see it's virtually none with these little bumps when we have an outbreak. American Samoa is the most recent case of an outbreak. It happened in part because the folks who were mixing the MMR vaccine mixed it with the wrong stuff, and there were 2 deaths from the vaccine because it was improperly prepared. And that led to a whole bunch of stuff, including anti-vaccination folks sort of coming in America Samoa. And there were ended up being thousands of infections, a lot of deaths, and their healthcare system was completely overwhelmed. Overall, if you look at infectious diseases, this is looking at infant mortality rate over the last 100 years. It used to be that 1 out of 5, 1 out of 10 children died before the age of 1. Infectious diseases were by far the leading cause of death, and they are by and large mostly gone from our lives. It's really incredible. But out of that success comes a sense that, oh, it's nothing to worry about anymore. All right, so just talk briefly about the ethics, and we can vote again. So the obligation to vaccinate. One of the ideas is the easy rescue argument. And I think it's Peter Singer who uses this example. If you guys are walking along and there's a baby face down in a puddle of water and is drowning, do you pick up the baby and save them? I hope you're all nodding. right? Suppose you're wearing really nice shoes and your shoes will get ruined. Do you save the baby? Yeah. And he kind of goes through a series of examples until like the baby is a mile out in sea, it's a stormy day, you don't swim. Do you try to save the baby? Well, at some point you say, no, it's the chance that I can do this is pretty tiny, right? The idea, the easy rescue is that if I can help someone else and it doesn't cost very much for me, I should absolutely be doing it. So the one idea about vaccines is it's relatively easy for me to do it for my kid, right? It doesn't cost me a lot. It's not a big deal. The side effects are minimal. I have an obligation to help others when the burden is small. Another argument is this idea of the social contract that, someone could say, aha, if 97% of people are vaccinating their kid, I could not do mine. I don't take any chance for the side effects, but he's going to be fine because of herd immunity. This idea of the free rider, that it's not okay, that we all have to take this risk to protect all of us. This is a social contract, is another way of thinking about it. On the other side of this equation are this idea of right to bodily integrity, which is really becoming a big argument. It's the Florid argument, right? That this is my body and you should not be doing anything to my body without my consent. Which, by the way, let's point out, is one of the arguments for choice about pregnancy. That it's my body and I get to defend it. So we have to be careful to not think that the principles we use to defend arguments don't get used in other circumstances. And then there's this last thing about the well-being of the child. And that is if you're really thinking about the well-being of the child and you have a law that says, well, you can't go to school if you don't get vaccinated, well, then he's not in school. And that's not good. And maybe the family moves away from a pediatrician who could help them to someone who doesn't do any vaccines at all. And then maybe they live in a community where everyone has really mixed up ideas about medicine and science. So have you done that child anything good by excluding them from school? So there are arguments against mandates for vaccination. One of the things that I have to say drives me nuts the most is this idea that there are religious exemptions. There is no major religion that thinks vaccines are bad, right? And if you just think about the values part of it, our major religions are based on ideas of compassion, love, caring for others, right? So getting vaccinated absolutely fits with most major religions. And you sometimes hear these ideas, well, the way the vaccine was made included embryo, or it included some pig elements and so on. This has been looked at by religious authorities and said, no, that's not an issue. So people may have philosophical reasons for not wanting to vaccinate their child, but just to point out that there really are not religious ones. That's the Dalai Lama, by the way, doing a polio vaccine in Bangladesh. So how do we bring in, if I said, yes, we have the science, we have the best information available, how do we bring in, we can just ask the patient when there's one person, but how do we bring in the community view? So you can do surveys. In March 2025, a majority of people said that children should be not allowed to attend school if they're not vaccinated. I'll point out that a year ago, it was closer to 65%. So there's been a pretty significant drop. Um, then there's an idea of participatory democracy. And I'm just going to spend a minute talking about this because the problem with surveys is that you get people's rapid first thought. Yes, of course I think this. No, I don't. Participatory democracy is a much more interesting way of trying to get people's opinions about really important topics. And there's different versions of it. Deliberative polling is when you basically get a random sample of people and figure something out. A really good example, and I forgot it was done in Nigeria or somewhere else, but there was a country in West Africa that had a lot of oil money. And they wanted to know what's the best way to spend this to help our population. And so you can have a representative democracy, right? We're going to decide for our people who voted for us. But what they did in this case was they basically randomly across the country selected some folks. Thank you, Dr. Levin. And the technological genius. And they brought them to the capital city, and they spent 2 days over a weekend. And they had some experts talk about what the options were. We can spend it on education, we can spend it on healthcare, we can develop industry. And there was a chance for back and forth and questions. So people got really informed. And then they kind of asked the questions again. So you had sort of this random sample of the population who's now well informed about issues say, yeah, we think this is really the most important thing to us.
I
So
could
you can imagine doing something like that. There's also citizens' juries and things like that, where you can get beyond polling to get a sense of what people think. I will point out that in the history of vaccination, it's amazing, right? So if you think about smallpox, eliminated from the planet, absolutely incredible. But I want you to know, like 20 minutes after we introduced the vaccine, there were anti-vaxxers. And then almost immediately, there were people who said, it's not fair. You can't be forcing me to get vaccinated. And this has been we think of anti-vaxxers as being a relatively recent phenomenon. It's been true throughout history. And often with good reason, because many times the people who are forced to be vaccinated are the ones that have the least power in a society. So this idea that you're infringing on my liberty, and you're often doing it because you have power and I don't, is a long-standing part of the history of vaccination. So at the end of the day, there is clearly a conflict, right? That there are some people would say that the benefits to society outweigh individual rights, and we should be vaccinating. We're a nation of laws. There are limits to freedom. But others would say, I think individual freedom is so important that it's okay if some people die, that it's such an important value for me, such an important belief. Um, I put down risk tolerance. Has anyone seen the research on how much risk people tolerate? So there are systematic differences, and you'll see how this comes out in a minute. If you look at people who tend to vote Republican and people who tend to vote democratically for Democrats, people who vote Republican tend to tolerate a lot more risk. They're less worried about, oh, what would happen if you're not wearing a helmet when you ride a bicycle? What would happen if? There tends to be a higher tolerance for how much risk you take in your individual life. And so that sort of plays out, as you can imagine, in a variety of ways. So this is one study looking at state COVID policy. And there's been a lot of debate about the data and whether this data is good or not. So ignore the actual graphs. The data, what I want to show you is that if you look at, here's Florida and here's Texas. And what they looked at was if you did certain policy, this is the COVID number of COVID cases, what would be expected based on natural history? And here's Massachusetts, and you see New Jersey, New York, California. And what you notice is that Texas and Florida, according to this data, had much higher numbers of people getting COVID. And what they did in the study is say, if you look at state policy about, can you go to church? Do you have to wear a mask? Do you need to be vaccinated? A whole range of things, that there were clear differences between blue states and red states. And I raise this not to say that Massachusetts, New Jersey, California did it right. I raise this because it comes to the core thing, which is about what are the values of a society? And I, for one, will point out that when we were trying to figure out whether kids should go back to school during the COVID, remember the summer of 2020, should kids go back in school or should it be virtual? Some of my pediatrician colleagues and I were saying absolutely that the risks of not going back to school are extraordinary. And yes, there may be some deaths. And particularly for staff and for teachers, they're going to be at the greatest risk. But not having kids in school is going to be awful. And one of the things you heard at that time was follow the science. The science tells us that kids should not be in school, particularly in some of the northeastern states. And that drove me crazy because, in fact, science does not tell you what to do. It tells you what the risks and benefits are. It gives you some information. And you could argue that if you look, now, this is looking at the number of cases, and the number of deaths were clearly higher in Texas and Florida. But if you look at amount of school lost, it's pretty extraordinary. And one of my colleagues, Dimitri Christakis, looked at what is the lifetime cost of losing a year of schooling. And it's extraordinary. So an entire generation of children is at risk of earlier deaths because they didn't get that year of school in some ways. So I show this not to say that there is a right answer in the policy you choose, but to the degree that your policies reflect your state and how they think about things, it makes a difference. So vaccines have risks and benefits. Values, beliefs, preferences gets you the right to admission. So we have to have a transparent process that asks the community. Um, Here's the right answer, by the way, for those of you wondering about what to do with mandatory vaccines. And it's called libertarian paternalism, right? This is my right answer anyway. And it's kind of a weird term, but basically what it says is that people make mistakes all the time in their choices. So we should set things up so they make the right choice by default. And the classic example, at least until recently, was on your retirement funds. That if you leave it up to a 20-year-old or a 30-year-old, even a 40-year-old, they're going to make bad decisions. They're not going to save money for retirement. But if you take a certain amount out of their paycheck and put it into an S&P 500 index fund, they're going to be much better off. So that should be the default. That happens automatically unless they say, no, I really don't want to. And so the whole idea was you basically structure the choices, but then you preserve freedom of choice by saying, well, you can opt out. And the way you can do this with school is you say, yes, vaccines are required to attend school. If you want to opt out, you can opt out, but there are things you need to do. You need to like, here's the form, you need to fill it out, you need to get your pediatrician to sign it, you need to get it notarized. So you make that a choice that someone really has to make and not just simply, I forgot. Because pediatricians will tell you that August, right before school starts, is the craziest time of the year in a pediatrics general peds office because everyone is just remembering their vaccines. They all come in to try to get them at the last minute because there is a school requirement. So this probably is the best way to maximize herd immunity and individual freedom. Um, in real life, we don't necessarily do such a good job in making sure that there's a process in place. And this is the last couple of things I wanted to talk about. So many of you will remember that there was a COVID pandemic, and we had concerns about what would happen if we ran out of ventilators. At the time, I was chairing the Florida Department of Health Ethics Committee. And we thought this would be a great opportunity to sort of go through the different things you can do. Like, how can you think about this? How can you figure it out? Um, and it ended up that our committee got disbanded before we had a chance to do the work. And in fact, in Florida, I want to tell you this example because it tells you how cool Dr. Goodman is. Um, we didn't have a state policy. Some other states decided that here's what we're going to do in our state. Um, Dr. Goodman, who helped figure out the policy for Jackson hospitals, and he and I did some of this work together with people with disabilities and had a broad range of folks from our ethics committees, um, ended up working with the Florida Hospital Association because the Florida Hospital Association was very interested in saying not every hospital is like they're doing their own thing, but we sort of have a common policy. And so it ended up being that our Jackson policy ended up being kind of the standard bearer for most of the hospitals across the state in good measure because of Dr. Goodman. So we did not follow a process in Florida that I might have said was best, but we did get to a good place. And again, some people would argue that the best way to do things is to let these sort of things be organized outside of government. Um, Very proud of this. You'll recall that one of the things that came out of all those discussions in those days was do these policies that we're trying to put in place, which we're using what are called SOFA scores. Like if someone's unlikely to live, they should not get the ventilator. If someone's more likely to live. And there were a lot of concerns that this would be systematically unfair to people who had diabetes, hypertension, obesity, and then in particular, Hispanic people, Black people, others who were underserved in most of our medical institutions would be unfortunately left out in these kind of algorithms. Um, and what we did, and you can't really read all this, you don't have to, but we had half a dozen medical students, I think, Ken, who got up at 6 a.m. every day for like 2 months and basically ran our algorithm as if we had to use it on people who were in the ICU at University of Miami Hospital and at Jackson. And so by the end, we had data on a few thousand, I think up to 5,000 different patient days. And we basically ran the numbers and said, well, does this policy discriminate against people based on race ethnicity? And the good news is it did not. And I think this leads us to the last idea about policy and the right decisions, which is if you continue to ask yourself questions and monitor it, again, that's one of the ways you make sure that you're on the right path. So this was a study that came out right around then. So conclusions, ethics is embedded in everything we do. I think questions always have answers because we have to answer them in real life. And if we use scientific information and the right process, then we can get to the right answer. So now I'm interested in what you guys have to say. And I might actually even stop. Should I stop sharing? Yeah, so that we can see. Thank you, Esther. So I really do want to hear what works and what doesn't in this because I'd like to keep doing it less for academic audiences, but more for county commissioners in Volusia and Flagler County, for folks that are just starting to think about it. I did one practice run at coffee hour at my church afterwards to sort of see, could I explain randomized controlled trials? Could we talk about the value of science? Because right now, this is a big problem. So I'd love to hear what you guys are thinking or questions that you have. It can it She was raising her hand. Just say your name before you speak.
Hello, I'm Camilla. So the first step in the process is best available evidence.
Hmm.
However, within that, you have lots of known unknowns and even more unknown unknowns. So how do you account for those in your decision-making process?
Excellent question. And I think this comes back to one of the issues why some people have lost faith in the healthcare system, and particularly public health, is there a sense that we haven't done a good job of explaining, number one, that one of the reasons why scientific knowledge is special is that because it does change over time. That as we get more information, as we critique each other, we get to better answers. And that is, in fact, a strength and not a weakness of scientific knowledge. That's one thing. The second is that we sometimes were presenting with absolute certainty. Masks don't work. Don't bother using them. You must be masked. It's the only thing to do. And a lot of people think if we were able to be a little more honest about, yeah, vaccines have side effects. One in 30,000 children is going to get ITP. That if we are upfront about what we know and don't know, that transparency helps build trust. That's a hypothesis. I'm not convinced about it, but it's a hypothesis. So the answer is we always have imperfect knowledge. We always have unknowns and unknown unknowns. All we can do is say, here's the best information available we have. And the special epistemological status of science, right, if people push you on this, is that we try to systematically look at things. We try to eliminate bias. We have control groups and we have peer review and we have other people trying to prove that that guy was wrong. And so you have a whole system. Ultimately, it's based on trust, but that we do have a system that tries to get to the best information available continuously over time. So the answer is by doing our best to get the best information we can, always being imperfect. You don't buy it. She doesn't buy it, Ken.
Well, keep going.
No, yeah, that's what I'm saying. She needs to tell me why she doesn't buy it.
So I
See, it's a
think
dialogue.
I think that's I agree in a research setting and in a discussion setting, but in trying to use a pragmatic approach, for example, in the ER where I work a lot, if I'm trying to counsel a parent on whether your child needs antibiotics and I convey that there is a little bit of uncertainty about the microbiome, for example, about, long-lasting effects of possible hearing loss if your child does and end up having an ear infection, things like that. Um, you showed how the approach to risk varies so much from person to person. I don't have time to explore exactly what their approach to risk is, so I don't really know how to, you know, use all of this information to give a pragmatic answer to people.
I love it. And I would say that whenever I teach this to med students and residents, that's what they say all the time. I don't have time to go through and find out people, okay, I've done this. I'm not going to do it right now, but I've had them time me how long it takes. It's 48 seconds, more or less, because you don't have to go into all the details. The research on decision making shows that 80% of this people make decisions based on their gut, based related to values. Only about 20% are information seekers and want to know, wait, what's the percentage of the microbiome that gets changed? Right? Most people don't want to hear about the details of study. They want to know most children, 8 out of 10 get better. If you give the antibiotic, 9 out of 10 get better. So it's a little bit better, but you then have a risk of diarrhea. And if people say, well, tell me more about the side effects, then of course you can get into it. But then it almost always comes down to, are you the sort of person who wants to let nature take its course? Because that's a reasonable approach and not intervene only if you have to. Or are you the sort of person who's like, if something might help even a little bit, I want to try it. I'm someone who wants to get it done. Um, Another example would be routine colonoscopy, right, for looking for colon cancer after age 50. And if you look at that difference versus fecal blood testing every year, right, there is a slight improvement if you do colonoscopy. But clearly, some people are like, I want that increased, ability to detect cancer, even if it means I have to go through that horrible prep, come in the hospital a day, do that stuff. Others are like, I don't want to go anywhere near a hospital. I hate it. I'm going to do that little, thing on the piece of paper once a year. And I recognize I might lose a little bit. And the research shows, again, that it's not, people don't care about the details. They want to know the big difference. So I think you can probably do it most times. We can talk more afterwards if you like. Yes, Amanda.
How do you respond?
It,
Oh, sorry. How do you respond to people who
or quickly, how do you respond quickly to people in your audience who might say exactly what you mentioned, vaccines, my body, my choice, bodily autonomy, and applying it, say, well, if you want bodily autonomy for, you know, women's reproductive health, then it should be the same for vaccine policy. Or, for example, making it more difficult, that libertarian paternalism,
Right.
making it more difficult for someone to get an exemption, sort of thinking about their best interest. So making sure it's a deliberate choice and not a fast decision, and applying that also to women's reproductive health, like making it more difficult to get a termination of pregnancy because you want them to really think about if you terminate this pregnancy.
So what you're getting at is that, look, there are fundamental disagreements on values because we are a pluralistic society and people think differently. It's hard for us because we tend to think, of course you can get the MMR vaccine, right? The benefits are so much greater than the risks. It's an obvious thing. But part of what we have not done a good job, I think, in the medical community is recognizing that there are other people, and we may disagree with them, who have very different ideas about bodily integrity in this case, or that might be the way they're describing it. And so the argument I'm trying to make is that good policy tries to take that into account. I was recently talking with a Medicaid director in another state and suggesting this kind of policy. And he basically said, Jeff, unless this really matches the values of my state, it's not going to stick. It's not going to work. It's going to get overturned right away. So the question is, how much work can we do, practically speaking, to try to get the sense of a society? And that's what I showed you with the differences in Texas and Florida in their approach to COVID mandates. And that's okay, right? Now, what's hard is that in a state as big as ours, there are a bunch of people who, there's going to be a really large minority who feels like, you're outlawing things I want to be able to do, or you're not, right? So we all think probably that fluoride on average, is probably a benefit. And taking away that choice from local communities is going to be a problem. In participatory democracies, there is a way, the next election, to change that.
Those were the days.
Yeah.
One of the challenges that you've identified, of course, is not only is it a question of literacy, or we talk about health literacy. We've advocated for ethics literacy. How about policy probabilistic theory literacy? When I've learned that I think if you walk out of doors in Florida, there's a 1 in 8,000 chance you'll be struck by lightning, even on a clear day. Those odds are really good for walking outside, but there are some people who, when they hear that, will actually think about walking around outside. When you apply that to someone's child, or when you apply that to your own healthcare, how do we educate people about ultimately rationality in the face of probabilistic data and imperfect information? Or if you could solve that, then you'd be in charge of the world.
Yeah, right. So as you point out, Dr. Goodman, most people have a lot of trouble with math, and oftentimes the bigger the denominator, the more that they think it's a bigger number, right? And so it's hard to realize it's an inverse relationship. I will say that I think for most people that the numbers matter less. And I'm going to come back to something that Dr. Goodman asked before, where I was seeing a patient and it was time for the flu vaccine. And this is a family that for 20 years now have been taking care of various kids. It's the last kid, and they've never wanted a flu vaccine. And I was talking to mom about how, this is a big flu year and we've already had some deaths. And she said, Dr. Brosco, I trust you so much. If you told me to jump out the window, I'd jump out the window. But the flu vaccine, I'm not so sure. And I said, well, I have a grandson now, and he's going to get the flu vaccine as soon as he can. And she said, did you actually go to the factory and check to make sure the vaccine was okay? And I said, no, I didn't. She said, well, when you do that, then I will take the vaccine. And part of the reason why I raised this question, Barry, is that there's even within this idea of trusting your healthcare provider, this range of views. And for that mom, I'm not going to spend any more time talking about the flu vaccine, right? Because it's pretty clear that I'm not going to be going to the factory itself to check on it. Most people, though, aren't that far into it. And whether it's 1 in 8,000 or 1 in 80,000, they're more interested in what their trusted information brings. And hopefully it's us. Targeted mistrust.
That did not go to the manufacturing plant where her car or her car seat were made, yet she trusted that they were safe to buy.
Yeah. So for those of you who can't hear, Dr. Goodman's pointing out that it's Dr. Gelman, excuse me, I didn't mean to insult him. That is that it's targeted mistrust. That it's about the pharmaceutical company, but they didn't necessarily say, I need to go to the factory to check to see how my car was made or to see how the food was prepared in the restaurant, right? That we are trusting people all the time in the things that come to us. And sometimes we have these narratives that take hold about, for example, vaccines, and it's hard to fix.
And deliberate attempts to undermine trust that has served us very well for a very long time. So you started it earlier. As we've been doing this for a very, very long time, the intellectual community that Jeff and others have helped foster on this campus has made the Miller School, I believe, one of the leading institutions of its kind, well, anywhere. We've been talking about those ideas, Dr. Brosco, for a very, very long time. And thank you for acknowledging that I shan't be doing this very much longer. This will be the last of these. I think I introduced the speaker. Thank you for making it an opportunity to sort of wrap this up with you.
Thank you very much, Dr. Gibb.
And thank you all very much. Please join me in welcoming Dr. Brosco.
No getting rid of them.
With that, that's just